Parkinson disease part 2. Neuroimaging studies can be useful in confirming a diagnosis of Parkinson disease. MRI is typically normal. Single photon emission computed tomography SPECT using iofluopen permits visualization of density of dopamine transporters in basal ganglia. It is approved by US FDA for differentiation of Parkinson disease from essential tremor and normal pressure hydrocephalus. But it cannot distinguish Parkinson disease from atypical Parkinsonian syndromes. PET imaging can be used by 18F fluorodopa, which shows decrease in fluorodopa uptake in basal ganglia. Differential diagnosis. Diagnosis of Parkinson disease is made on history, clinical examination, absence of incompatible clinical laboratory radiographic abnormalities. The features that suggest atypical Parkinson syndrome is symmetric onset, absence of tremor, early gait abnormalities, early falls, prominent freezing, early postural instability, dementia that precedes motor symptoms or occurs within first year, corticospinal signs, cerebellar signs, abnormal eye movements, other than restricted up gaze, symptomatic orthostatic hypotension. Second differential after atypical Parkinsonian syndrome is drug-induced Parkinson. Drugs that block dopamine receptors, typical and atypical neuroleptics, certain antiemetics, or deplete striatal dopamine, which are dopamine depleters such as reserpine, tetrabenazine, can cause drug-induced Parkinson. Symptoms usually improve slowly or resolve after drug withdrawal. Anticholinergic drugs can improve Parkinson syndrome, which is caused by drugs. So antipsychotics, antiemetics, dopamine depleters can cause Parkinson disease. The third differential of Parkinson disease is normal pressure hydrocephalus. The fourth differential is lower body Parkinsonism, which is caused by vascular disease or vascular Parkinson. Vascular Parkinson is gait disorder with freezing, loss of postural reflexes from multiple lacunar infarcts. Response to levodopa is not significant in vascular dementia and tremor is rare. The differential diagnosis of Parkinsonian syndrome in young people include Wilson, young onset Parkinson, and pecan neuroacanthocytosis and Huntington disease. Now it is pharmacotherapy. Treatment of Parkinson disease. There is no medication to stop, slow, or reverse or prevent progression of Parkinson disease. Treatment is individualized to symptoms and signs of disease. Levodopa is most potent agent for Parkinson disease in early mild PD. Response is good. The adverse effects of levodopa are dyskinesias and motor fluctuations. After 5 years, 50% patients have fluctuations, that is wearing off and sudden offs, dyskinesia, and they represent both pre and post synaptic changes related to disease progression. Maximum dose of levodopa is 2400 mg per day, and it is available in immediate release, controlled release, inhaled, and intestinal gel form, which is called DUPA. Don't use levodopa as a first-line agent and prescribe less potent agents such as Monoman oxidase B inhibitors, amantadine, and dopamine agonists as monotherapy in mild stages of Parkinson disease. Indications for starting levodopa include disabling symptoms and signs such as postural instability and falling, bilateral motor symptoms, decline in ability to carry out activities of daily living. If patient is unable to tolerate dopamine agonists, don't obtain significant symptomatic benefit from dopamine agonist older than 70 years and has cognitive decline. Levodopa is converted to dopamine in brain by amino acid decarboxylase, and it is combined with a peripheral dopamine decarboxylase inhibitor such as carbidopa, which inhibits peripheral conversion of levodopa to dopamine and permits greater amount of levodopa to cross blood-brain barrier. And it also decreases peripheral dopamine-induced side effects such as anorexia, nausea, vomiting. Levodopa is taken 3 times a day, and it is taken with meals to prevent GI upset. Protein intake may compete with levodopa transport in duodenum, so protein redistribution diet should be given, which means protein meal should not be given with levodopa, and it should be given thereafter. Long-acting formulations of levodopa such as Cinnamide C have slower onset of effect, less bioavailability, and longer duration of effect, and they reduce motor complications. In 2015, FDA approved an enteral suspension of Levodopa, which is available by the name Dopa. It is continuously infused into jejunum, and it is used in case of motor fluctuations. But it also has complications such as infection related to catheter, tubing, and hardware. Adverse effects of levodopa include anorexia, nausea, vomiting, confusion, drowsiness, hypersomnolence, vivid dreams, nightmares, hallucinations, postural hypotension, and cardiac arrhythmia. CNS adverse effects dose related and require reduction in dose. Now, the second class of anti-dopaminergic drugs are dopamine agonists. Dopamine agonists act at D1, 2, and 3 receptors. Dopamine agonists are the most powerful anti-Parkinsonian medications after levodopa. Dopamine agonists are synthetic compounds that stimulate striatal dopamine receptors, and they are first line and monotherapy in mild Parkinson's disease. Don't prescribe these for patients older than 70 because confusion, sleepiness, psychosis can occur. Patients with Parkinson's disease who are older than 70 but otherwise mentally and physically younger can be given dopamine agonists. Dopamine agonists can cause drug-induced dyskinesias and motor fluctuations infrequently. Monotherapy with a dopamine agonist is rarely sufficient after 3 years. So, other agents are combined with dopamine agonists. Dopamine agonists are available in oral agents such as ropinirole, pramipixole, immediate release, extended release, transdermal patch, rotigotine. They can cause sleep attacks when driving, impulse control disorders, pathologic gambling, shopping, excessive sexuality, nausea, vomiting, sleepiness, peripheral edema, orthostatic hypotension, psychotoxicity, illusions, hallucinations, and mania. Stop the drug or decrease its dose when these effects occur. Drug selection is based on ease of titration and clinical experience. If adverse effects occur, an other agent can be tried. If a sufficient therapeutic response is not attained, other agents are added, such as Monoman oxidase B inhibitors, amantadine, trihexyphenidyl. Apomorphine is a non-ergot dopamine agonist, and it is available in subcutaneous injection to rapidly treat sudden severe disabling of period. Side effects of apomorphine include severe nausea, profound hypotension, dyskinesia, hallucinations. Severe nausea and vomiting, antiemetics such as trimethobenzamide are used in combination. The protocol of apomorphine is give domperidone 36 hours before giving apomorphine. Start dopamine drugs 4 to 6 hours before giving apomorphine. 1.5 mg apomorphine is given every 30 minutes and maximum dose is 7 to 10 mg. Now the third class of anti-dopaminergic medications are Monoman oxidase B inhibitors, and these are selagiline, rasagiline, and safinamide. They increase dopamine by impairing its metabolism via monomer oxidase B. They have possible neuroprotection for selagiline, rasagiline. They can be used as initial therapy for mild symptoms or as add-on therapy. Dose of selagiline is 5 to 10 mg every day, and there is a risk of they should not be given with foods containing tyramine. Safinamide is taken in dose of 50 to 100 mg daily. Monomer oxidase B inhibitors should not be given with serotonergic agents, including antidepressants such opioids, SSRIs, which can lead to serotonin syndrome. Safinamide is used for off periods. Monomer oxidase B inhibitors are contraindicated with meperidine, tramadol, methadone, propoxyphene, dextromethorphan, and St. John's wort. In these cases, they can lead to serotonin syndrome. Metabolite of selagiline is amphetamine, which results in improved alertness and insomnia. Monomer oxidase B inhibitors can cause side effects such as dyskinesias, tremor, confusion, psychosis. There is amantadine, which is anti-glutaminergic and anti-Parkinsonian, anticholinergic, and antiviral. Amantadine has mild dopaminergic effects. It augments release and inhibits reuptake of levodopa. Anticholinergic effects, anti-glutaminergic effects. It is effective in both mild and advanced Parkinson's disease. In mild Parkinson's disease, it decreases Parkinson's disease symptoms, especially tremor. It is effective in decreasing levodopa-induced dyskinesias, side effects, peripheral edema, confusion, libido reticularis, rash, visual hallucinations. The dose of amantadine is 100 mg twice a day up to 400 mg per day. A long-acting form of amantadine is approved for dyskinesias, which is called Gocovri. Then are catecholamine oxymethyl transferase inhibitors, entacapone and tolcapone. Entacapone is used with levodopa to extend on time duration of action of levodopa by inhibiting enzymatic conversion of levodopa to its metabolites. Side effects of entacapone include diarrhea, dyskinesia, or in discoloration of urine. Entacapone is available in 200 mg tablet and taken simultaneously with levodopa. Entacapone levodopa combination is available as Talivo. Tolcapone can cause fulminant hepatitis, death, explosive diarrhea. So baseline and biweekly liver transaminases should be obtained. It should not be used except when fluctuations are disabling and other drugs fail. Other drugs to treat Parkinson's disease are anticholinergic drugs such as procyclidine and trihexyphenidyl. Anticholinergics improve tremor and they are most useful in tremor predominant Parkinson's disease. Bradykinesia and rigidity may be improved. Peripheral and central side effects can occur such as confusion, forgetfulness, blurred vision, constipation, dry mouth, urine retention, hallucination, psychosis, especially in older patients. So they should be avoided or minimum dose should be used in older patients. A weak anticholinergic such as diphenhydramine, amitriptyline can be used instead of trihexyphenidyl in older patients. Benzodiazepines such as lorazepam 0.5 to 1 mg twice a day can be used for anxiety. Hallucinations are more prevalent with dopamine agonists than with levodopa. To treat hallucinations of Parkinson's disease, two drugs can be used. First is quetiapine 12.5 to 25 mg at bedtime and other is pimavanserin. But clozapine can cause agranulocytosis. Pimavanserin is selective serotonin inverse agonist and it does not cause extrapyramidal features like other antipsychotics. The other treatment of Parkinson's disease is surgery. Regarding surgery, first is ligation of anterior choroidal artery, which supplies medial antiform nucleus and globus pallidus, and it abolishes tremor. The new treatment is deep brain stimulation with electrodes implanted in subthalamic nucleus or globus pallidus. DBS can also suppress a medication refractory tremor in Parkinson's disease. Medication dose can be lowered post-surgically, often reducing dopamine-induced dyskinesias. Electrodes implanted bilaterally for bilateral symptomatic improvement, but surgery can be done only unilaterally. DBS is reversible. Pulse generators can be turned off. Electrodes can be removed. DBS is better than best medical therapy. It should be performed earlier before the onset of gait imbalance, freezing, dementia. The other neurosurgical procedure is a stereotactic leaning using focused ultrasound gamma knife radiosurgery in Parkinson's disease, which targets ventral intermediate nucleus of thalamus and ablates a disabling tremor, avoiding placement of brain electrodes and attendant hardware. But it can also be performed unilaterally. Now the question is, the patients candidate for deep brain stimulation, who should be candidate for deep brain stimulation? First of all, patients should have typical Parkinson's disease, not atypical, post-traumatic or vascular. There should be excellent response to individual doses of levodopa. Dopamine dyskinesias such as wearing off, motor fluctuations, medication refractory tremor. Cognition should be normal. Patient's general health should be good. No uncontrolled diabetes, hypertension, and support network should be excellent. In the end, there is prognosis of Parkinson's disease. Parkinson's disease is neurodegenerative disorder, worsens slowly over time. It is influenced by age at onset, lifestyle and medical therapy. In the end, patients are immobile, mute, bedridden, and succumb to complications of immobility leading to death.